In a case of syncope or loss of consciousness or a seizure, using our mnemonic old cards will note the onset or when did it start. For the location, in a case of a seizure, we'll ask what side of the body was seizing. For the duration, since one is unlikely to be constantly syncopal or seizing, we want to know how intermittent are your episodes. That is, how long does an episode of syncope or seizure last for, and how many episodes are you having per day or per week. Next, we can note the progression. Do your episodes appear to be occurring more frequently? Or if there has been no progression, we'll also be sure to state that in our patient note to show that we asked. To help characterize these episodes, we'll use our technique of pre, present, and post, as we'll see below, and aggravating and alleviating factors. And again, if there are no aggravating and alleviating factors, we'll also be sure to include that in our patient note to show that we asked. On the pre-syncopal side, we'll ask about the context, or what were you doing beforehand, and if there were any auras or warning signs, such as nausea, sweating, palpitations, lights, or smells, as we'll see below in vasovagal syncope. On the present side, we'll ask how long was the syncope or seizure, and for seizure activity, it's high yield that we break it down and ask individually about any shaking, tongue biting, or urination. On the post side, we'll ask, was there any sensory numbness, motor weakness, or confusion after your syncope or seizure? And again, it's high yield that we ask about these individually because we could have one of them without having the others. For all cases, we'll order a CBC and serum electrolytes. And since a syncopal or loss of consciousness episode is concerning for an underlying etiology, we'll order TSH, T4, EKG, and Holter monitor to rule out an arrhythmia, an echocardiogram and an ultrasound of the carotids to rule out an embolus, and a CT of the head to rule out any intracranial pathology, such as a hemorrhage or a tumor. In vasovagal syncope, our supporting points will include a loss of consciousness that's aggravated by a change in an autonomic drive, such as standing, emotional stress, or pain, which is producing the autonomic prodrome of nausea, sweating, or palpitations. And if our patient asks us what can be done, we could help counsel them that lying supine and elevating the legs if they feel this coming on again may help. In a case of a generalized tonic-clonic seizure, we'll see loss of consciousness, and now with seizure activity, there will be associated tongue biting or urination, and we could have a post-ictal state, or numbness, weakness, also known as TOS paralysis, and or confusion. And we'll add to our workup an EEG. In a transient ischemic attack or a stroke, we'll see a loss of consciousness with transient or ongoing sensation, numbness, tingling, motor, weakness, ataxia, or speech deficits, and our patient will have a history of risk factors, hypertension, diabetes, or smoking, and we'll add an MRI of the brain. In an intracranial mass, we'll see a loss of consciousness with a morning headache or a headache that's aggravated by lying down from the increase of CSF. We could also have the sensory loss, numbness, tingling, motor weakness, ataxia, and a hearing loss. And we could see the characteristic findings seen in cancers: weight loss, decrease of appetite, and night sweats. We could also have a positive family history, and we'll order an MRI of the brain. In a cardiogenic syncope from an arrhythmia or aortic stenosis, among others, we can see a loss of consciousness, and it can be aggravated by exertion, a history of palpitations, and no seizure activity compared to convulsive syncope coming up next, and an absence of a prodrome of nausea, sweating, and palpitations, as we saw previously with the vagal syncope. In convulsive syncope, the mechanism of action is cerebral hypoperfusion. So any event that's producing low blood flow to the brain, even an arrhythmia, can produce a convulsive syncope. And we'll see here the loss of consciousness will have a seizure activity, and there will be no post-ictal state, as we saw previously with generalized tonic-clonic seizure. And we'll add an EEG. In an orthostatic syncope, we'll have a loss of consciousness. It can be preceded by lightheadedness, and it will typically be aggravated by standing. Our patient can report a history of diarrhea, and we know by now, since diarrhea is a bodily fluid, to use our mnemonic A, B, and C for the amount, if there's any blood, and the color for our patient note. Or our patient can have a history of antihypertensive medications, which can also be revealed to us in the vital signs if we have a blood pressure less than 100. And we'll add here orthostatic vital signs, and if our patient is reporting diarrhea, a stool culture. In hypoglycemic episode, we'll have the loss of consciousness preceded by lightheadedness with the typical hypoglycemic episodes of sweating and palpitations. We could also see the neuropathy, numbness, tingling, and our patient will have a history of diabetes on insulin. and we'll add here an A1C and a serum glucose. And finally, in alcohol intoxication or withdrawal, we can see the loss of consciousness with an altered mental status in an intoxication, or withdrawal seizures in a withdrawal. Also, we could see withdrawal symptoms of nausea, sweating, and palpitations. So we see it's very important to ask about any auras or warning signs. And for our workup, we'll order an AST, ALT, and an EEG. We'll start our neuro exam with hand sanitizer, and we want to ask our SP if we have permission to examine them.
Yeah.
Okay, and we're going to start with a hint exam, and we're going to use it as a guide to help us out. So for the head, we could comment that it's normocephalic, atraumatic. Move on to the oral pharynx. So we'll use a tongue depressor here. The key thing to do is you don't want to add too much pressure. For the SP, so just very lightly, you can press down and ask them to please stick out your tongue. Okay, and we'll comment that we don't see any lesions. We'll examine his thyroid, and so another good tip is to offer a glass of water. Would you like a glass of water? No. Okay, and now we could look to see if there's any visible lesions to the thyroid, and we don't see that, so we could ask him to swallow, and we could do one side at a time. Okay, now please swallow again. Okay, we didn't feel any palpable thyroid nodules. Transition to the cranial nerve exam. For cranial nerves, 1, we don't really assess cranial nerves, so we could kind of use that as a hint or as a placeholder to test their alertness and their awareness. So we could ask them, what is their name?
Glitching.
And where are we right now?
The clinic.
Okay, good. And what time of day is it right now?
Afternoon.
Good. So now we could verbalize that they were alert and oriented ×3. Okay, now we could transition to the rest of the cranial nerve. So for cranial nerve 2, ask them to look straight ahead, and we're just going to check their pupillary constrict the response, and then we're going to do the same thing on the other side. We're going to do the same thing here, and then we're going to do it on the other side. Good. Now we could verbalize that they were pearl, the pupils were equal and reactive. We're going to transition to cranial nerve 3, 4, and 6. So please, you'll instruct them to please follow your fingers with their eyes, keeping their head straight, and you can see that he's able to follow. Okay. Trigeminal nerve, cranial nerve 5, and we're going to assess this with sensation. So please close your eyes and let me know if this is equal.
Mm-hmm. Mm-hmm. Mm-hmm.
Okay, good. So for cranial nerve 7, we're going to go ahead and ask him to please smile, puff out your cheeks. Okay, don't let me pop them. Close your eyes real tight, don't let me open. Cranial nerve 8, and we'll ask him to please close your eyes and let us know what side you hear this.
Left.
Okay, you hear this louder on your left?
Yeah.
Okay, good. So that would be a concern now if he has hearing loss on his right hand side. So continue with cranial nerves 9 and 10. So you could ask him to say "ah," please, and we would try to stick out your tongue, and we would visualize that we could see a non-deviated uvula. And while he's out here, we could also ask him to move his tongue left to right, and we could say that his hypoglossal nerve, cranial nerve 12, is intact. And now we will finish up with the cranial nerve 11. So please shrug your shoulders. Okay, so they're equal. And look that way and resist me. Okay, and look this way and resist my movement. Good. And now we're going to continue with MSRP. So for motor strength, please make a muscle for me. Okay, and resist me. So 5 out of 5, full reflection, and extend 5 out of 5 on extension. Great. Now we're going to do sensation to light touch. So please close your eyes and let me know if you feel this equally on both sides.
Yes, I do.
Okay. Now we're going to do a pinprick. So please let me know if you feel this on your left.
Oh, yeah, I feel it.
Okay. Now we're going to do the same thing on your right. His reflexes. So we're going to look at his biceps reflex. We'll place our thumb on his biceps tendon, and this would his normal reflex would produce a 2+ response. Okay, and if we were concerned for a case of B12 or hyperreflexia, he would have a 3+ response. Okay, you would see that. Now we could assess his radial pulses as well. So we could do 1 at a time, 2 at a time if you're more comfortable, and we'll verbalize that it's a 2+ pulse, regular rate and rhythm. After we completed the MSRP for his upper extremity, we can now move down to his lower extremity, and we could do the same thing. For motor strength on the lower extremities, could you please kick out? Okay, good. So that's 5 out of 5. Now could you please kick in? Good, 5 out of 5. Now we'll go into sensation. So please close your eyes and let me know if you feel this equally on both sides.
Yes, I do.
Okay, great. And now we're going to go into pinprick. So this is a pinprick. I'm going to start on your left side, and please let me know if you feel this all the way down.
Yes, I feel it.
Okay. And now I'm going to go onto your right side, so please let me know if you feel this.
Yes, I do.
We could instruct him to relax, and we'll do a patellar reflex. So a normal patellar reflex would be like 2+, and then if we were concerned like hyperreflexia or B12, we would get a hyperreflexive response. So just relax, and you would see something like this. And we can continue to demonstrate with the tap on his Achilles tendon. So we'd start right here, and we would we would get a normal reflex, and if this was a case of B12 and we were concerned about hyperreflexia, he would give us a dramatic response. Okay, you feel that. We could also test while we're down here a Babinski, so we could start on the bottom of the sole and go into the big toe. And note, if he had a positive Babinski, his toes would curl up. For the pulse, we're going to go behind the medial malleoli, and we'll feel for the pulse, 2+ pulse. And then we could do the same thing on the left extremity and verbalize we have a 2+ bilaterally. Okay, now that we've finished with the lower extremity, we'll go ahead and hand sanitize again. And we'll ask our SP if they could please stand up and walk straight. And come back. We'll go ahead and listen to the heart sound. The mnemonic we want to use is department M225A. That stands for the aortic, so we'll check that aortic first in the second intercostal space on the right. And then we're going to go to the pulmonic side. Go to the tricuspid. And then we're going to go to the mitral. And if this was a female patient, a tip you could use is lift their breast up. Okay, we could make a comment that we heard audible S1, S2, no murmurs, rubs, or gallops. Start off listening, we'll switch it over to the bell, and we'll use that to listen above the clavicle. And the instructions you want to give is, when you feel my stethoscope, please breathe in and breathe out. Okay. We could just set the bed to 30 degrees for the carotid exam. Ask them to go ahead and please lie down. Then you don't want to forget to extend the leg rest. Okay. Once we have them lying down, we can now cover them up again. And we'll start the carotid bruit exam. If you could ask the patient to please look to your left. And we're going to use now the bell of the stethoscope to first listen. Okay, and you make a comment that there's no audible bruits, and while he's still on the side, you can now feel for the pulse, and you can comment that there's a 2+ pulse, regular rate and rhythm. Do the same thing on the other side, so you can ask the patient to please turn, listen. Okay, you can make a comment that there's no audible bruits, and then feel for the pulse again, that it's a 2+ pulse, regular rate and rhythm. To finish up the cardio exam, we would just like to auscultate for the PMI on your left side, please. And just feel that it's not displaced at all and it should be in the 5th intercostal space. And it's also very important not to forget to auscultate for the PMI on the patient's left side and under the gown. If they were wearing a gown, we would go under the gown and we would just listen real quick.